Welcome, my friends, to the Bob and Brad podcast. My name is Mike Peanuts, and today I am interviewing Dr. Stephen Cramer. He is a stroke neurologist who does clinical research and focuses on neural repair after central nervous system injuries in humans, and he has an emphasis on stroke and recovery of movement. So he does many different treatment options. He is a researcher and he works at UCLA. We talk about a little bit of everything, including new and upcoming treatments. And we even talk about robotics a little bit. So without further ado, here is Dr. Cramer. Well, welcome to the podcast, Dr. Cramer. Thank you so much for joining us today.
Thank you. Thanks for having me.
So today we are talking about stroke rehabilitation. And, interesting enough, when I asked AI who the best stroke expert was, your name came up. So that's a fun fact for you.
You know how much I had to pay AI to say that?
So my first question is, can you share your background story with us?
Sure. Well, currently I'm a professor of neurology at UCLA, and the medical director of research at California Rehab Institute. When I wear a white coat, I'm a stroke neurologist and an internist still. And most of the time I'm in the lab trying to do research that asks the question, when somebody has a stroke or spinal cord injury or traumatic brain injury, and they lose movement in their arm or leg, what can we do to get that movement back? How do we restore voluntary movement? And so we do study clinical trials of therapies. We'll talk about some of those. And we also study biomarkers, which are tests you can do to figure out how to match the right patients with the right therapies. It's like a blood test or an EKG kind of thing, but for the brain. My background, I was born in Philadelphia. We're kind of lower middle class. Neither of my parents went to college. And I think early on, I just saw physician as a great way to help people and maybe get out of the ghetto kind of thinking. And then when I was in high school, I started reading about the brain, and I was like, brain plus doctor. I'm going to be a neurologist. This is so obvious. And so trained in internal medicine, then neurology, then stroke. I got the research fever as an undergraduate at Berkeley, and I've just never stopped wanting to answer questions about neurology, and then about stroke, and then about recovery from stroke.
Yeah, I feel like in school, either you like stroke and neuro or you just despise it. It's like,
Right.
so you typically specialize in it or you don't.
It's a very lovable thing to despise. So I despise it from the base of my heart. But in terms of stroke, can happen anywhere in the brain and rob people of any number of human functions. Some of them you don't even see. They're just operating under the ice, kind of thing. And so I think the complexity of it is something that appealed to me, and the universality of it. It's so common in our society. And so it's something that needs attention.
So where can people find out more information about you online?
The best thing I could say is to open up a browser window and type UCLA Steve Cramer, and or stroke recovery Steve Cramer, and a whole bunch of stuff will come up. I don't know if I have a better answer than that, but I'm all over the web if you type those things.
Yeah, I'll link your UCLA website before. That's where I kind of found your information out about you. So we're going to start discussing stroke rehabilitation here. So what are some of the most significant changes you've seen in stroke rehab since you've began your career?
Right. Well, there's good and there's bad. Let's start with the bad. Nobody wants to pay for it. So only a quarter of people with a stroke get admitted for inpatient rehab, where you get lots of attention and lots of rehab therapy. Most people are sent home, and where if they're lucky, they get maybe a dozen physical therapy sessions or a dozen occupational therapy or speech sessions. But even then, most people don't. And then a quarter are sent to a skilled nursing facility because we don't know what else to do. Just keep them going. And the amount of resource provided to people after they've had a stroke is dwindling. So 20 years ago, if somebody was in the lucky 25% to get admitted to inpatient rehab, the average length of stay was 3 weeks. And now it's 2 weeks. And this is partly a reflection of the payers. Nobody wants to pay for it. And partly a reflection of people like me. We need to give the evidence why that is money well spent. Stroke is disenfranchised population of patients. Uh, I haven't seen a parade down Main Street with people wearing ribbons for stroke. People crawl under the woodwork. They withdraw from society. So there's dwindling resource for something that, in my heart, I believe is a very good thing for movement, for psychosocial factors, for the caregiver. Right. On a positive note, um, we're really chipping away at the biology of rewiring the brain after stroke and other forms of brain injury. And we're getting a better understanding, which is hard to summarize, but you get the idea. And but there's also been therapies. So I was part of a team that that did a pivotal phase 3 study of vagus nerve stimulation. We can unpack that, but if you stimulate a particular nerve in the neck, people have a better response to rehab, and it's approved by the US FDA. And we're seeing, I'll give you one other example. We're seeing more and more solid data that giving people intense doses of rehab, not a couple of sessions, but really boot camp going at it, produces substantial and enduring gains in function that they carry with them for a lifetime. So there have been some losses, more societally, and there's been some real gains for treatments and in the regulatory sector.
Yeah, it is unfortunate. Oh, I just realized my monitor's in the screen. There we go. Yeah, I remember working with a lot of rehab patients that had strokes, and we always tried to keep them going as long as we could, but unfortunately, insurance always wants you to see progress. And I felt like with the majority of them, they would keep progressing even after we're done with them, just because it can take so long to get some of those functions back. I remember having a younger guy, it wasn't a stroke, it was a TBI, but he actually saw speech therapy for a while and he couldn't eat. And our old speech therapist thought he couldn't. And then years later, all of a sudden he could eat again. So it just shows you like the neural pathways can change as time goes on.
Right. You know, there's a negative and a positive there. On the negative side, um, we did one study where we followed people for 3 months, 500 people, and we found that 50% of Americans with a stroke in this study got zero physical therapy, and 50% got zero occupational therapy, and two-thirds got no speech therapy. So um, it's just not happening. On a positive note, we know that if you do it, um, you get benefit, but you got to go at it hard.
Sure. So, for our listeners who may not be familiar, can you explain what stroke rehabilitation entails?
Right. Well, there's no one easy answer to that. Most people, if you ask them, the quick response, which is pretty accurate, is you get that physical therapy if you have problems with walking, and you get occupational therapy if you have problems moving your arm or with functions around the house, and then you get speech therapy if you have problems speaking or using language. Um, in reality, there are some other complexities. Um, some people are fortunate to be connected with a medical team that continues to follow them. So you might continue to see a stroke neurologist or a rehab physician, sometimes called a physiatrist. Not everybody gets follow-up appointments, or they get just one, but the medical team can be part of it. And for some people, you know, maybe a third of people have depression by a year post-stroke, and maybe a quarter have serious anxiety or PTSD. And so some people also see a psychologist or a neuropsychologist. Um, there can be driving training. There can be recreation therapy, just helping people ease back into their lives. There can be help for the caregiver, which is kind of outside the brackets of what we're talking about, but is absolutely no less important. So it's a complex mismatch. It's that way in part because of the way it's designed in the US, and because we're a capitalist society. I'm not dissing capitalism. I'm just saying stroke doesn't fare well in that environment. But it's also because every patient with stroke is so very different. I mean, no two patients are the same no matter what the disease. But in stroke, the area of the brain that's affected and the size of the injury and the symptoms that result and the severity of the symptoms are so different from person to person. And so the definition of what is stroke rehab for Mr. Jones and Mrs. Smith, these are very different too. So there isn't one answer, but that gives you sort of like an overview.
Sure. Yeah, I remember we had numerous stroke rehab people, but we happened to have two around the same time, and they knew each other. And one was actually a retired physician, like the old small town doctor that knew everything. And just for them having that social, like they were doing this together, just helped them out so much. But I mean, yeah, they both had pretty severe strokes, unfortunately.
Yeah, we're social creatures. Um, I might be getting a little ahead of ourselves, but one of the programs in my lab is to use telehealth to deliver rehab. You put a computer with games in their home, and then every other day we have a licensed OT or PT like Zoom in. And when we did a qualitative study and said and it works real well. Um, what did you like most about it? It was the social bonds they formed with the therapist. We're social creatures, and that's such a big part, probably for all diseases, but especially for stroke, which can be so isolating.
Yeah, one of the stroke rehab people I talked about is on Facebook, and I don't work at that facility anymore, but she still keeps in touch because, like, I worked with her initially right away, and you kind of form these bonds with them. It's pretty
Right?
interesting.
Yeah.
So, what are some common misconceptions about stroke recovery that you encounter?
Oh, I call it neuronihilism, and there's no room for it. No, not on my team. Um, People say, "Well, once you've had a stroke, that's it." Um, I think that's the biggest misconception out there. And here's how I refute that um, in exact statement, which is if you treat enough stroke patients, you know the following is a very safe statement, which is that everybody shows some spontaneous improvement after stroke. Obviously, it's not usually enough, um, but sometimes it's spectacular. But everybody improves something, right? And so that's something to realize that it's not, oh, look what's happened, tisk tisk, we're done here. Um, Instead, there will be some improvement. The second is that once that spontaneous improvement hits a plateau, which can be a few months for some things and can trickle in over years for other things, that there's nothing we can do about it. But as I've said, um, practice, practice, practice. Sometimes when I lecture, I show a picture of a trumpet and I say that trumpet isn't going to learn to play itself. You get in there and you practice, and you'd be surprised how much most people can get additional function back. They got to work hard at it, and they're not used to working hard to get a spoon to their mouth without spilling, or to walk to the mailbox and back. But if you practice it, you can. So we don't allow neuronihilism in the lab. The last thing is, this is a little touchy feely, but let me go there for a second, um, which is a misconception is, well, your life is over once you've had a stroke, or that's horrible. But when you talk to people, and there's studies to this point, when you talk to people who have a substantial disability after their stroke, and you let the initial air clear, because initially it is a shock, it's traumatic. But you catch them a few months or a year later, they're happy to be alive for the most part. They can still put their grandkid on their knee. They might need both arms, but life goes on, and with a little help reorienting, people continue to enjoy life. So one of the most common misconceptions is that life ends with a stroke or life becomes terrible. But I push back on that hard.
Yeah, I mean, some of these people, yeah, unfortunately, I've met people that had a stroke and then have had another stroke a few months later and passed. But I've worked with people that had stroke like 8, 10 years ago, and they may need assistance, but they're still functioning and they're enjoying themselves.
Yeah. So I started an organization called LaserNet, the Los Angeles Stroke Rehab Network. See what I did there? And we have an annual stroke awareness picnic where stroke survivors come onto the UCLA campus. And People across the full range of post-stroke functional impairments, and people are happy to be there. People are happy to get out. Sometimes it's how you frame it. I'll go on one tangent. I'd say uh, when I'm working with people clinically after stroke, the thing I recommend the most is headspace, meditation, to spend some time training yourself to listen to your thoughts and challenge negative thoughts or hostile thoughts, and be in control of your thoughts. And as people get a little bit more skill at that, they remember that is a nice sunrise today, or I do like the flavor of jasmine tea, or that little kid is cute, et cetera, et cetera.
Yeah, it's just good to be not focusing on the past, but what you can still do in the moment you're in. So my next
basically.
question, sorry, didn't mean to interrupt. What are the latest advancements in stroke rehabilitation that you are most excited about? You seem to be in the forefront of some of these, huh?
Um, I work hard and and publish my results. There's a lot there. Let me try and organize a few. So we could divide it up into research that tries to understand the disease better. And before you poo-poo that, if we don't have a solid base of evidence and research findings, then we're shooting in the dark when we try and come up with the next best therapy, right? So one class of thing to get excited about is some of the advances in the basic science of what's going on in the brain. And then the other class is of actual research studies for something that we can prescribe for Mr. Jones or Mr. Smith tomorrow. So thinking about the first one, thinking on my feet, um, the animal studies are teaching us a lot. Now, I know not everybody likes animal research, but if you wear my white coat, you're grateful for all of the new lessons that come and inform what we should be doing for humans. And I'd rather not debate that, but that's the color glasses I see the world through. That meaningful research that really teaches us what to do for our patients is reasonable. Um, and we're learning in particular about which molecules and genes change after a stroke and are therapeutic targets. So, if a brain level of some key chemical like dopamine goes down after stroke, then hey, I got an idea. Let's give people something that ups brain dopamine, like that kind of thing, right? Um, on the human side, basic research, we've been involved with some genetic studies. So, we've got 20,000 genes or so, and each gene has different flavors. Think about blood type. Some of us are A or B or O, right? And think about eye color, right? Different eye colors. Well, we have the same kind of variation in the genes that make the brain work. And what we're finding is variation, genetic variation in some of those genes tells us whose brains are better at rebuilding and whose brains are worse. And it's starting to give us some idea about what we can anticipate. Imagine if on day one after a stroke, when we're still doing the TPA and just getting organized, if we could say, well, I know where this person's going to be, what they're going to look like in 3 months. And here is my personalized plan that is informed by this anticipated trajectory. That's a much better job than, well, I see what's wrong with you. I don't really know where this is going. So let me take my best guess as to what's going on. Um, so we know about some people get these genes tested when they have certain cancer treatments. There are cancer treatments that, for lung cancer or breast cancer that only work if you have such and such gene, but not the other flavor of that gene. Um, and sometimes we see this for Alzheimer's. There are certain genes that put people at increased risk for Alzheimer's. And there are clinical trials that say, all right, we're only going to enroll people who have that gene, but not the other flavor. Well, I think that day will come for stroke recovery too, where if we know somebody's stripes of genetic variation, we can better anticipate what they need. Um, then there's the treatment things. So I mentioned vagus nerve stimulation. It's been approved for many years in the US for people who have really bad epilepsy seizures and the drugs aren't cutting it. If you zap the vagus nerve, it's this little nerve that runs in the neck right between the jugular and carotid. So obviously it must be important because of the company that it keeps. And it senses throughout the chest and most of the belly certain kinds of information called parasympathetic, the rest and digest information, and sends that information straight to the brain. And it turns out if you increase the amount of activity in that nerve, the brain is more amenable to plasticity. So we paired vagus nerve stimulation with training and found that those people had better benefit from training than the people who got training alone. So, and that's approved by the FDA. Full disclosure, I consult for the company that does that, but I consult for every company that knocks on my door. I just love
Sure.
helping people stroke recovery. I mentioned Rehab in the lab. For years, so we built robots and had people come to the lab and put their hand in a robot, and when it trained their arm, we focus on arm movement in the lab. When it trained their arms got a bunch better. But then, one patient said to me, Dr. Cramer, if I could get to the clinic, I wouldn't need to get to the clinic. And I was like, I see what you did there. We started putting similar devices in the home. So we developed a tele-rehab program where uh, the person sits in their home, often in their pajamas, and does intensive daily rehab, again, with a therapist zooming in every other day. And we found spectacular gains in function from this program. And the studies continue, but can I say this? There's a company that made a version of it called trcare.net, trcare.net, and they have a version of this thing that people can look at. So telehealth is the future of all medicine. I'm not saying that whether you like it or not, that's what it is. It's cheaper and comparably efficacious, and the capitalists are going to shove it down our throats. Oops. But so we're trying to adapt that for rehab after stroke. We've seen some good benefits. There's also exciting developments, cell therapies, growth factors, drugs, including repurposing drugs that are already commonly used for other things. So we're seeing a lot of advances in treatment, including some things that have been recently approved. I could go on and on about that, but that gives you the flavor of where I'm at for that question.
So I'm just gonna ask a couple follow-ups. For the gene testing, is this like a blood work or mouth swab or something more in depth, or how does that done?
All of the above. Probably the easiest way to think about it, and the method that we used in our last big study, big national trial, was spit. Because when you spit, hopefully you keep the lettuce out of it. But in regular spit, there's enough cells that come from the whole salivary duct in the cheek. There's enough DNA in there. So think of 23andMe as a model. They mail you a spit kit, you spit into it and ship it back, and then we've got gobs of information about your genetics. I do want to mention there's a risk with getting somebody's genetic data. There's a risk that hostile forces will capture it. There's a risk that it could be used against you. We never do that. We keep everything in locked, encrypted computers, but there is risk. And so we always have to balance risk with benefit. And we think it's worth it. You can get genetics from blood as well. But for research dollars are so scarce, we have to be lean and efficient. And if we have to have somebody come in and have a blood draw, apart from the pain we're inflicting, financially, it's much more expensive. So if we can get what we get with the U.S. Postal Service and spit, then that's the route we go.
So with the vagus nerve stimulation, is that like kind of like electrodes you put on the neck, or is it some other mechanism in order to stimulate that?
Surgery, my dear man.
Oh,
So um, they so this is, as I said, this is commonly done for epilepsy where the drug stopped working. Also approved for depression where the drug stopped working. It can help some people where nothing else is helping. Same surgery. They make a little slit on the left, and they take a little tiny stimulator and wrap it around that nerve, avoiding not pissing off the carotid artery or the jugular vein. And then they stitch it shut. And then they run a little wire down. Think of like a pacemaker looking thing under the skin here. And somebody can push a button on the controller and wirelessly activate stimulation of the vagus nerve right as you're about to practice your therapy move. And that sends signals up to the brain that promotes plasticity, promotes rewiring to a degree that you get more bang for the buck for the same rehab experience. That's what we found in our big study.
sure. That reminds me, I actually, sorry, I digress here, but I heard the recent patient one of the, what is the Elon Musk thing they are putting into the people?
Yeah, the Neuralink chips.
Yeah,
Yeah,
Neuralink. Yeah, I just heard the first patient as a quadriplegic just had it inserted. It's kind of interesting to listen to that.
yeah, that's a whole other thing. So let's take a tangent for a second on brain-computer interfaces. Um, so I'm going to go full George Jetson on you for a second. I think that in the next 100 years, we are all going to have gobs of computerized implants in our bodies, perhaps in our brain. Brain is trickier. And we're going to welcome, I for one welcome our new silicon overlords. Because you can, when it's the data are there, you can do things that you couldn't do before. Obviously, it has to be tested and found to be safe and has to be not hackable, etc. But I mean, we already put little computer things. Somebody needs a pacemaker. There's some computer parts in there. And so the idea that we can put a little computer chip in the brain and capture the person's intent. Let me back up. A brain-computer interface takes the parts of the brain that are still working fine when other parts have been blown apart. It takes the parts that are still working fine and records the signals from them and uses those signals, decodes them through a computer to get behavior done. So if my movement centers in my brain are completely intact, but their ability to send messages to the arms and legs has been blown up, you can record from my brain, and with perfect resolution, a computer can turn that into what my intent is. So if you take a monkey who can't move his arms or legs, and you put such a chip in, and the monkey sees like a bowl of grapes on the other side of the room, which he really wants, he learns within 1 day how to control the robot arm that grabs the grape and brings it to his mouth. I mean, it's spectacular, right? And so the idea that 1 day will be good enough to use that for humans. The problem is not the computer to decode it. The problem is getting the chips in the brain, because the brain is kind of like fatty, waxy stuff, and it's not easy to. And nature has spent millions of years protecting the brain from anything getting inside it. So there's a groups, at Brown, Cleveland Clinic, at Pitt, who are putting, a little bit more aggressive hardware than a small chip, and through the brain, through the skull into the brain, and can get the same results in humans. I think what's special about Neuralink, to the extent that I understand it, is it's more implantable and less sticking outable.
Yeah, I remember he had the very first one. I think there's 3 humans that have it now, and he said it's in there still, and he's got like some hand function back, but they said some of the connections have already like released and came out. So when they go in again or put a new one in, they're gonna have to fix that. But like the body itself just kind of like pushed part of it out. Some of the connections, I guess.
Right. We have one project. I'm lucky enough to collaborate with Jeff Ogerman at University of Washington, where we're going to put a series of chips in, because the brain doesn't work necessarily by one brain zip code getting the job done. The brain works in networks, much like humans. Everything is done in a network, and we're going to try and stimulate multiple areas in a network and get network function back. This is something that seems to make a good deal of sense. It was just approved by the FDA, so and it's funded by NIH. So hopefully, we'll be able to offer this to our first enrollees soon. There's less invasive forms of brain-computer interface. So we're just finishing one study with my colleague An Do at University of California, Irvine, where the story is this: a common thing after stroke is that people can't walk because the mechanics, the muscles in the leg aren't right. So they drag their foot. A foot drop is a big problem, and not just for stroke, for lots of things. And so the brain says, let's get walking, and they're doing all their best. But when it comes time to swing the foot up to the next place, it just drags, the toe drags on the ground. They're at risk for falling. I'm sure you've seen this numerous times in your patients. And so what we do is, instead of doing any surgery, we just put an EEG cap on. Think of it as a heavy winter hat. And it records the brain signal to lift the foot. Let's allow that our smart computer engineers, Zoran Nenadic is our computer engineering guy. So if you allow that, I can capture the brain's decision to try to unsuccessfully lift the foot. We capture that and then wirelessly send a signal to muscle stimulators on the calf muscles, the tibialis anterior, whose job is to lift the foot. So as they're walking, their foot lifts right when it's supposed to, because the brain thought it. And so we're just finishing a trial where we added that to physical therapy training for gait. That would be an example of non-invasive, non-surgical brain-computer interface. Because we're not getting into the brain, we're limited as to like how granular, how much resolution we have on the information we extract at the level of the scalp. But that's still something that it works. The question is it significantly better than physical therapy alone? And I should be able to tell you that in a few months.
Yeah, it's pretty cool. Yeah, just an exterior device. You can just walk around with a different hat on, and you can walk functionally. That's pretty fascinating.
As long as it says Phillies, then it's a good hat.
I don't know. I'm from Minnesota. I don't mind the Phillies.
Yeah. Right.
All right. So we've talked about technology a bit, but do you want to explain a little bit more about how you use robotics and virtual reality within your practices?
In my research practice, um, and what I know of clinical practice elsewhere, um, um, uh, there, there's a lot of stuff going on. What in particular did you want to focus on?
How to use robotics? I know you talked about the robotic
Yeah,
arm at times. So, are there other ways or things you do with those?
right. Um, ro- th- there's good and bad about robots. Robots do exactly what you program them to do. You don't have to pay them benefits. Um, and they are connected to a computer, so you can gamify it and you can record exactly what's happened. Sometimes it's hard to know what dose you've given somebody. Um, and some of the downsides are some robots are safe, some you have to have a human standing there to make sure that nothing funny happens. Um, and they're also limited in what they do to what you told them to do, right? And so where I see robots having the biggest presence is usually in the clinic and sometimes in the hospital. So sometimes a patient will come in and they'll go to the rehab gym, and the therapist will put their arm, in a robot that helps them practice moving their arm a particular direction, right? Or they'll put them in a robot for gait, and they'll practice walking, and the robot keeps them safe, and they can do large amounts of dosing. Um, Robots can be expensive, sometimes very expensive, and sometimes they need some degree of human supervision for the most part. Um, and so they have an impact, but I don't know how much impact they will have moving forward because of some of those limitations. I would love to be wrong, or love to see new science supersede that perception. Um, and what was the other kind of therapy you want to talk about?
You talk about. I know I watched one of your videos from UCLA website of on YouTube of playing games for rehab, and you had much more patients actually do their homework when they get to play a game.
Oh yeah. Well, yeah. So after we were doing the robots for a while in the lab, and we started putting in the home, we faced a serious question, which is how do we motivate people to do this? Um, you ask people, they want to get better, but you ask them, do you like doing rehab? And you get a little bit more mixed answer, right? So we said, well, what do people like doing? Um, well, so here's a story. So I go to Vegas. Never mind that. And I'm walking into the buffet, and there's the lady, with the purple hair stripe thing and the gray hair, and she's banging on video poker. And I'm like, look at those beautiful proximal arm movements once per second, right? And I come out of the buffet, like 3.5 hours later. Never mind that. And she's still there. I'm like, wow, I want my patients to move their arms once per second for 3.5 hours. So, boom, we got to get people playing video poker and call it rehab, all right? And that's our most popular game. Um, and shooting ducks. People love shooting ducks, dude. So we made like a gaming pistol, um, and people shoot ducks on the screen, just like they're in an arcade. We totally emulate that. You get the idea. We have a Guitar Hero like game. Calm down, lawyers. It's a Guitar Hero like game. Um, and people love playing that, right? And how many hundreds of millions times has that been purchased or downloaded? So we are trying to tap into why people like games, and in the convenience of the home, telehealth, use that to drive rehab. Um, uh, the average rehab therapy session, there are studies that look at this. If you count how many arm movements they make, that it's 30. I just did 10% of a rehab session. With our system, depending how you define it, we have over 1,000 arm repetitions in a session, and people's function really improves. And I think a big part of it is games. Let me go one more. Uh, One of the problems with stroke recovery is that somebody has another stroke, or that they're not taking care of their physical health. Um, People are stubborn. People sometimes don't know the knowledge. People have their set ways, and I'm not coming after that. I'm just saying this is the issue that we face as clinicians, right? And so we felt it was incumbent upon us, while we had their attention at a computer screen, between video poker and Flappy Bird to educate people about stroke. So we play Stroke Jeopardy. I hope the lawyers don't start calling now. We play Stroke Jeopardy, and we'll have like risk factors for 1,000. And we teach people with daily Stroke Jeopardy about their disease, about how to recognize a stroke, how to respond it, and also importantly, how to prevent the next one. So we gamify education, which traditionally is hard to get people to do, and we gamify intensive rehab, which might otherwise be hard to do. And as I say, we throw in the social thing with a licensed therapist working as hard as they can with somebody. Our compliance in our last national trial, 98% of the sessions that were assigned were majority of minutes were performed. So I think there's something to this gamifying therapy.
Yeah, it's a lot more entertaining to do something that you can actually see results on versus just going through a range of motion for 30 repetitions. I mean, most people, the person that doesn't like going to the gym, but they love playing a sport, it's kind of the same concept. Your brain's engaged, you're focused on something else. It just seems like people are going to actually do their homework then.
Yeah, we give a lot of feedback and reward as people play. So when somebody shoots a duck, that duck dies. And we had debates in the lab as to how bloody the duck should get and how sad the sound is when the duck gets hit. But people need to know that they just shot that duck, et cetera, et cetera.
Yeah, for our listeners, it reminded me of Duck Hunt when I was a kid.
Yeah, right. It's fun. And there's Space Invaders, because I grew up in the Valley in the 70s.
Oh, yeah. I remember Space Invaders.
As they get down there,
yeah, they shoot them. So can you explain the role of neuroplasticity in stroke recovery?
Sure. It's a broad question, so let me break it down a second. So let's define our terms. So neuroplasticity is when something in the brain or spine changes how it works. It might be a structural change. Neurons are thicker and have more, antennas, or it might be a functional change. Here's a circuit that underlies generation of movement, and that circuit is humming at a much better RPM kind of thing. But something changes about the brain. And stroke recovery, we can think about spontaneous recovery. Like I said, the first few months, everybody gets something back. It's just not usually enough. We could talk about stroke recovery being like treatment induced. Yeah, to take the red pill or the blue pill, and things are going to get better. So we all undergo plasticity right up to the very end. So I would say if a listener remembers one thing about this conversation tomorrow, it's not magic. Something in your brain encoded that and stored that. That's plasticity. Memory is a form of plasticity. The brain has a little memory file for, did he really say shooting ducks or whatever, the one thing you take home from this. Right. So plasticity is universal. We're all doing it. You can see plasticity in sea slugs. Right. So it's a common thing. Right. So what we're trying to do is get lots more plasticity and the right kind of plasticity. Plasticity can also be an enemy. So about 1% of people have a stroke. By 1 year, they're in agonizing pain. It's particularly some forms of stroke in some neighborhoods of the brain, but the brain has interpreted incoming signals touching the hand. And because some wires are cut, the brain listens to those signals coming in and says, oh, that must be severe pain, right? And it's hard to treat. It's and 1%, it's not rare. Or some people after the stroke, they develop epilepsy seizures, maybe 5-10%, depending who you ask. And that's the brain working differently than before. So it's not all good. Similarly, if you go to a physical therapist in another country and they don't know what they're doing and they give you intensive therapy, they can make you worse than if you didn't get that, right? So we want to induce plasticity. We want the brain and spine and nerves to work better. And we want to do it through the right kinds of treatment. We want to induce the right kinds of plasticity. We could open up a whole other hour about what that means, but we want to make things work differently in a better way that produces enduring and substantial gains in function, enhanced treatment-induced stroke recovery.
Sure. Yeah, I don't think our audience wants us to get too in depth with that question. Probably get too nerdy for them. So,
You do not want to open up that subject with me at a cocktail party. 'Cause
so we talked about this a little bit, but what role do you think artificial intelligence and machine learning will play in the future of stroke rehab? I know we talked about the implants and the external devices. Is there anything else we didn't touch on?
um, yeah. Well, like with everything else, it's coming, whether you like it or not. Um, and it's going to improve performance in some jobs and probably take some jobs. Um, and you can't argue with the following statement. Um, Once it's refined, there are things AI can do that a human can't or can't do nearly as well. And the challenge will be to pick the right bits from that basket and not go too far. I sometimes worry that programmers, that uh, Silicon Valley companies with limited clinical experience might be a little over enthusiastic about uh, the proposed acceptance uptake of their agenda at this time. But one day there will definitely be things we can say that's a good thing. Um, Imagine a doctor who stumped on a case and AI comes up with some good suggestions and the reason why. Imagine a patient whose rehab 10 sessions that all insurance will provide are done, and AI says, I've looked at this, hello, Dave, I've looked at this person's scan, and I think that this person would benefit from another 10 sessions. So there might be a rosy side to it, to all of this, right? Um, and so I think it's inevitable because we will in America. And I think that there will be positive sides. There was also risk with it. I'm not qualified to enumerate those risks, but we just have to make sure that we don't hurt anybody as we incorporate new computer advances, computer capacities.
Sure. Yeah. I mean, it's every job it's getting integrated in. And obviously, you know, im- using AI externally to help with things is a lot different than internal AI, implant in your brain. But time will tell, I guess, in this realm.
Yeah.
So, what advice would you give to stroke survivors and their families as they embark upon the rehabilitation process?
Um, get informed, fight back. Um, so, um, the funniest thing in the world is when I lift the hood of my car, because unless there's like a plug and a socket sitting next to each other, I have no idea. I am so uninformed when it comes to cars. Um, we could talk about that another time. But right, I think, and so what I did do was I went to neurology and stroke school for like a lot of years. I got my first job at age 35, so I know about that, and probably most people don't. Just like they probably know so much more about cars than I do. Okay, just as one example. Um, and so if a stroke is in somebody's life or your neighbor's life or your loved one's life and you don't know much about it, I'll get educated at it. And I don't mean go to, some weird website, like read a bunch of websites from common places. Read the UCLA website and Mayo and Harvard. And these are, you can trust the content, especially if you see it across multiple websites, right? Um, and the academic tend to be free of commercial bias, although they have their own bias. So get educated, and then ask the questions. Now, I will be honest. If you come into the doctor's office and you have 30 minutes with them, and you plop down 200 papers you printed, 200 pages you printed, and you say, "I want to talk about these things," maybe you might be selling yourself short, right? But if you come in with 3 or 4 key questions, well, I read about vagus nerve stimulation is an option. I don't mean to pump that so hard. I read that higher doses of rehab can help a person. Can we get that for my loved one? You can really help. It's not as if your doctor or physical therapist or occupational therapist or your national practitioner is selling you short. It's just they have their agenda and their focus. And if there's something that you want to focus on, get educated about it and work with your team. Maybe make another appointment just to focus on your questions. If you had to focus on medications at the first appointment, right? The other is fight back. I don't mean that quite so punchy, but the system is built to provide good care and works on average. And if you feel that the average response has not met your needs, stand up for yourself. or wheel over for yourself, or have your loved one stand up for you. And there is a thing where squeaky wheels get more oil. Now, I don't mean complain about things that are trivial. I don't mean to make fights for fight's sake. But if you're like, this is still not right, let's talk about what options remain. Go back to the doc politely and gratefully. Express your point, but you have to buck the system, or you get the on average treatment, which is generally very good in the U.S. But for many people, there are still unchecked boxes, and push back on that politely and gratefully. Push back on that, and maybe see a different doctor or nurse or a therapist if you feel that this one doesn't have an outlook that's aligned with your own. There's nothing wrong with that. If a guy couldn't fix my car and I thought it was fixable, I would have it towed to another station, kind of thinking.
Sure. I think that's well said. So I got one last question. What keeps you motivated and passionate about your work in this field?
Mm. Well, there's a lot of answers to that. I have severe ADHD, so my mind is always I don't really have a say in that. Um, I love helping people. So in my culture, we have a phrase, repair the world. And so I wake up motivated to leave the world a better place than I found it. It sounds kind of mushy as I say it out loud, but that really is true. That's where I'm coming from. Um, and there's a curiosity. I guess as a kid, I was a curious type, and as an adult, I'm a curious type. And I just wonder how it works and what we could try and so forth. Um, as a white coat type, as an MD, I can't look out on the stroke ward and not feel a need to do something more. And in my career position, that means researching new ideas and new treatments. So I guess it's cultural and genetic and occupational.
That keeps you motivated.
Keeps me going.
Well, thank you so much for joining me today. Do you have any last remarks you'd like to add or anything I forgot to mention?
UCLA is a fantastic stroke center, and California Rehab Institute is a fantastic rehab hospital. I'm lucky to work there.
I will link everything for you down below in the show notes section for anyone listening, and thank you so much for joining us today.